Okay, so last time we've talked a bit about the uroliths, the types, because it's very, very important to know all the diagnostics behind it. And me as an internal medicine person, I think that it's the most crucial thing. And now we're going to go on the most interventional part of the uroliths, like, for example, how can we retrieve the uroliths? And there are many ways. We're going to talk about voluntary, not voluntary voiding and catheter retrieval, because you already know that, about voiding hydropropulsion, which is very, very successful in many cases. And I suggest that you go into the Minnesota Urolith Center webpage and see more details about it. We're going to have some pictures from them today. And there are also some explanatory videos for you to try the technique. It works. It really works, especially in female dogs, but also in male dogs. We're going to talk about basket retrievals, the indications and the limitations of what kind of limitations we have in order to do a transurethral basket retrieval, and some intracorporeal lithotripsy methods with or without basket retrieval, because once you do lithotripsy, sometimes you can then use voiding hydropropulsion. And to be honest, don't overact with the basket retrievals in the urinary tract, because you might, after repeated attempts to take the smashed uroliths, the fractures of the uroliths, the fragmented uroliths out, you might traumatize the urethra. Okay. And if we have time, we're going to talk about percutaneous cholecystotomy and nephrolithotomy and basket with or without basket retrieval again. But this is more on the surgical side, and I am an internal medicine person, but I promise to you, for those of you who are into laparoscopy techniques, that I'm going to have a dear friend to explain all the urology lap-assisted techniques, because this is on the surgeon's side. So let's talk about voiding hydropropulsion. First, no need of specialized equipment, although I will show you that the collection of the urine has to be done in a very specific container. Otherwise, you will be full of urine all over your body. So how do we actually, this is one problem that we all have. How do we select the method that we will collect the uroliths? It depends, of course, on the size and the number of the uroliths that we have already diagnosed with our radiographs, our ultrasound. And we're going to talk about ultrasound a bit, because this is not a very appropriate method to measure the size and the number of the uroliths. They're mostly underestimated in the ultrasound. So I would rather have fluoroscopy or radiographs, first of all, and fluoroscopy in order to actually measure the size of the urethra, as we do in the urethral stenting, and then the ultrasound. So it depends on the size and the number of the uroliths. Stones that are less than 3 to 4 millimeters in small female dogs, stones that are less than 2.5 millimeters in female cats. And of course, in male dogs, we always have to beware of the size of the penile urethra in order for the uroliths to pass, because it could be dangerous if you pressure more and the urolith has a bigger size than the actual biggest diameter of the urethra. Another limitation that we have to think about is the sex and the species. So female dogs and cats, it's okay. It's not indicated in male cats because there is a high risk of urethral obstruction, and the diameter of the urethra is really, really small. compared to the uroliths that they form. Advantages, it's a quick, very quick, easy method. Of course, you need personnel, you need staff, especially for the large breed dogs. This is a method, for example, that for me has never worked in large breed dogs like Great Danes or German Shepherds or large breed dogs, because they're very heavy. Of course, there are techniques, and I'm going to show you, but they're very heavy to keep them in a vertical position. And it has not worked very well for me, but it has worked wonderfully well for medium-sized and small breed dogs. The advantages, so it's that it's quick, it's low cost, and it can be done by any general practitioner. And the disadvantages are that some stones may remain in the bladder, so you might not evacuate the whole bladder, and that some larger stones may obstruct the urethra. So you have to repeat the procedure maybe sometimes, but the danger of obstruction is imminent. So what is required? As you see, we require a urethral catheter, a stopcock, sterile saline or any equivalent, medium, flush medium, surgical scrub, large volume syringes. I prefer 60 ml syringes to have, sterile gloves, sterile lubricant, and a bowl or an alternative to collect urine and stones. You cannot put them in a urinary container that we put the samples for cultures. And the danger here is that you're going to be covered with urine because the pressure, I'm going to show you the procedure and you will understand. So in female dogs, as you see in the pictures, we have a vaginal dilator, and then it's easy to put the Foley catheter. And in male dogs, the same thing. If you have a problem putting the catheter in the bladder, you might do it cystoscopically. You might have a rigid scope and help you and guide you to do the catheterization. Okay. So we anesthetize the patients. Most of my patients are anesthetized. I could never do it in half anesthetized, sedated, slightly sedated, or alert animals. No way. Because we want to relax the urethra. Okay, you might and the dog in general, and you might as well think about epidural in order to relax the urethra, especially the tone, especially in male dogs. So you place the urinary catheter, you attach the three-way stopcock to the end of the urinary catheter in order to facilitate and to control your fluid flushing. And then you fill in the bladder with sterile saline or lactated Ringer's solution. So the dosage for that, because many people ask me, how much should I put? You will never, ever use an infusion pump. And what I mean the irrigation pump that we use, for example, for rhinoscopy, because many bladders have ruptured that way. You will use your stopcock, through the catheter, just your manual, you will have manual control of the fluid that you are infusing. Okay, and you always confirm with palpation, and it's 4 to 6 mLs per kilo approximately. But I always fill it with the palpation, with the urinary bladder palpation externally. So we position the patient so that the spine is perpendicular to the table, and or 20 to 25 degrees caudal to perpendicular. That's most likely to the larger breed dogs. And we agitate the bladder in order to dislodge the uroliths from the mucosa of the bladder mucosa, and then we remove the catheter. And then we express, I'm going to show you in photographs what we do. We place the animal in a vertical position, and you see that They use this table in Minnesota for the larger breed dogs. It's difficult. This was the difficult part for me. I had a German Shepherd and I had no luck with it. And then you try to express, you press a firm pressure in the bladder, and then the urine comes out on a stream, taking out many of the urinary stones that are in the bladder. Have you ever tried it? Please share in the chat box. And what difficulties have you encountered with the methods? Sometimes it works, sometimes it doesn't, but it's worth the try before getting into more interventional or cystoscopy procedures, because it might be, in many cases, successful. But I would love to hear your experiences in that. So this is what we get after the expression of the bladder, and some tips for you to have just before getting into the technique is that we definitely have to treat the UTI before voiding. Beware in every patient, especially the small breed dogs like Dashwoods or Pekingese dogs that might have a spinal disease. Beware of these animals because of the posture, the positioning of the animal. And if you can pass the golden rule is that if you can pass an 8 French catheter, then the urethra may accommodate a 2.7 millimeter stone. That's a tip, for you to know that if I can pass this size of a catheter, then the size of the stone that I can actually take out is up to 2.7 millimeters. This for the cases that you cannot measure approximately the diameter of your urethra. And for the cases that radiographically you might have bigger stones. So if you have many bigger stones in the urinary bladder and you only have a small amount of 2.7 stones, then it's not worth going into this technique and half voiding the urinary bladder. So the next techniques are the transurethral cystoscopy assisted techniques for the retrieval of the urinary stones. And we're going to say some things about the instrumentation, but I'm going to be very, very basic here on the instrumentation used for cystoscopy because our topic are the uroliths right now, and I'm going to go into more details for the more specific instrumentation that we used in uroliths retrieval. Okay, so for transurethral cystoscopy, we might use rigid scopes most of the times, and sometimes we might use the flexible scope, the 2.8 millimeter that I'm going to show you that ALHA has just released, and it's very, very good. So we use a 2.7 millimeter, 18 centimeters with 30 degrees angulation, the multi-purpose, actually, rigid scope with a cystoscopy sheath. And of course, we can have a biopsy forceps just lying next to us, because a fenestrated one, because you never know what we might encounter, and we might need, to take some biopsies apart from the uroliths. And you know why? We might have to take some biopsies because sometimes you take a urine sample, and the urine sample, the culture from your urine sample gives you, for example, one bacteria taxis, and then you give antibiotics for many weeks and it doesn't work. So it's resistant to the antibiotics that your actually sensitivity test showed you. So once you're going in to retrieve the uroliths, you're going to take some samples from the bladder wall mucosa in order to send it off for culturing as well, because there might be something else there that's keeping the animal from having a response to the antibiotics, and with the result of having recurrent UTIs. Okay, so always take a sample from if you have recurrent UTIs and urolithiasis due to UTIs, then always take a sample, not only for histology, but also for culture from your urinary bladder. And of course, the uroliths will all be sent for culture as well, not only for quantitative and qualitative analysis, but also for culture. Okay, grasping forceps, scissors. This is very, very handy. I'm trying to find some scissors here in Greece for the rigid scopes. Maybe AUHA will be of help with that, securing that we might have some scissors. Cell-safe biopsy sample frames. I don't use Eppendorfs in order to put my biopsies in, but I use frames, 2 giving sets, and normal saline, at least 1 to 2 liters. Cystoscopy is not performed with tap water. Okay, it's not like rhinoscopy that we can put in an empty normal saline bag. We can put, just dehydrogenized water or tap water. We try to keep things sterile while we're in the bladders. So you have to use normal saline, sterile normal salines or lactated drinkers. And for female dogs, more than 30 kilos, we can also use larger rigid scopes. Longer scopes also reach the rostral bladder wall better. And in giant breeds, the bladder is partially filled. And because we want to once we reach the opening of the bladder, the neck of the bladder, the problem is that we cannot reach the wall on the other side because our bladder is distended. So what we do is that we keep the bladder half filled, partially filled, and I have an assistant that's manipulating the bladder from outside so that it comes closer to me, and so that I can, for example, grab a urolith or take out a polyp in the urinary bladder, or take a biopsy from a spot that's on the other part of the mucosal of the bladder wall. Okay, so keep your bladders partially filled, especially that's a general rule, but keep your bladders partially filled, especially in the giant breeds, because you don't have enough length. There are also some rigid scopes that are really, really long, like the ones that I told you with 30 centimeters length. But most of us have the multipurpose one that has 18 centimeters. The maximum length is 18 centimeters. Even with that, you can do giant breeds as long as you manipulate the bladder from the outside. And then for female dogs, less than 5 kilos. So for most dogs between 5 to 30 kilos, the multipurpose is amazing. But for female dogs, less than 5 kilos, and for cats, the 1.9, the 2 millimeter scope, 18 centimeters length works better. This is this is the arthroscope, what we used to say as arthroscope, but it also can be used for bladders and noses in smaller patients. And we can also use a rigid scope in some male dogs with perineal urethrostomy. Okay, but you have to wait at least 3 to 4 weeks post-operatively in order to use the scope, and in order for actually the fistula to have been formed. And this is the cystoscopy sieve. This is actually the way that we are handling the scope. Your scope has not to be moving. Okay, And the newer editions now of our rigid sheaths have also a tap here, because unfortunately all the water comes out in your camera. So you have to tap your biopsy, your working channel tap as well. And you will find that more thoroughly in the catalog of AUHA, but even if you have some other brands, this is pretty much the same. The sheaths, the 2.7 multipurpose, the operating sheath, the cystoscopy sheath. Please work with the cystoscopy sheath, because the operating sheath has two disadvantages. First of all, some of the operating sheaths that do not have a biopsy, a working channel. And the second thing is that the operating sheath does not leave enough space for the water. So you have a very, very slow dripping of your normal saline. And this makes it very, very hard for the urethra, for the vagina to open, for the urethra to open, or for your bladder to get filled. This is what we have already said. The mini scope, the 2 millimeter for smaller patients, and the oval biopsy forceps, some alligator grasping forceps. And what about flexible scopes? So in male patients, I'd rather not do cystoscopy or any interventional cystoscopic procedures with the flexible scope, because the image can be obscured unless you have something like a constant flushing, a constant irrigation pump. But I think that we're liking the adapter so far. Katrina will update me on that for the flexible scope, in order to have a constant fluid irrigation. So we can use it in male patients. The diameter is 2.5, and the working channel is amazing. The biopsy channel is 1.2. We can have amazing biopsies. 1.2 for a 2.8 external diameter is pretty amazing. And we can also do some, it's the same thing. You can also do some balloon dilations as well through the scope, because in the urethra, we always go through the scope, or we don't go through the scope. We can go with the fluoroscopy without any endoscopy equipment, just with the fluoro and the balloon in strictures. Okay. And let's talk about a bit the positioning and the patient preparation. So before any procedure, you definitely have to have a complete history, full physical examination, coagulation profiles. These are patients that might have pyelonephritis, that might have kidney failure, that might have some coagulation problems. So you need to know these things upfront before getting in for any interventions. Definitely urinalysis, lateral and DV plane radiographs, always lateral plus DV. And I have shown you last time, for those of you who missed the first part, please go back to the first part and see the correct positioning for the lateral and the DV plane radiographs. We can also have an IV-epielegram, air cystograms, sometimes double construct cystograms, especially for radiolucent, for some stones that cannot be easily detected in the plane radiographs, a CT or a contrast enhanced CT. The soluble iodine construct medium Omnipaque, this is the one that we use most of the times. I know that this is the one that most of you have in your practices. Hyoxel as well can be used, but most of us use Omnipaque. This is the dosage, 800 mg of iodine per kilo. How do we do an air cystogram? This is very, very helpful sometimes. We put a Foley catheter into the bladder, we drain the urine, and then we inflate the bladder with carbon dioxide. because this is less likely to cause any air embolism. Having said that, I know that many very, very experienced endoscopists use oxygen as well, air. And so far, knock on wood, they haven't had any problem, but I really do not suggest it. If you have carbon dioxide, please, it's preferred. We want to have a fasting for 12 hours. General anesthesia in these patients is mandatory. Intubation with a catheter endotracheal tube, mouth gags. We actually don't use mouth gags here, but we're used to that. We don't use mouth gags because the endoscopic procedure is not from the front. The patient, now there are two schools about that. Some people prefer for the patients to be permitted to urinate before cystoscopy, and some others prefer not to, so that they can themselves actually void the bladder. I permit the animals to do whatever they want to do, to urinate before cystoscopy, but what we all have to do is definitely empty the bladder at the end of the procedure. Okay, and always keep your assistant observing the abdomen, because we lose the abdomen sometimes. And some of you, I know that you use irrigation, fluid irrigation pumps. Don't do it in cystoscopy, because as I told you, many bladders have been ruptured and you are not aware of it, because urine still comes out from the urethra. But you can see that the animal's abdomen is getting bigger and bigger and bigger and bigger, and you can detect that with your ultrasound fluid in the abdominal cavity. Don't stress over it. You know, you either, if it's a rupture in the urethra, then you just leave the Foley in. If it's a rupture in the bladder, then you can open and stitch. But if it's a small rupture, then, you know, you can just put a Foley and it will all work fine. Now, if a urine sample is needed, then we should obtain, this is why sometimes I just want, you know, I just want prior to my cystoscopy procedure to do a cystocentesis in order to have a urine sample. But most of the times I have already done that a week prior cystoscopy, because I'm looking for UTIs, as you remember. I'm looking for UTIs, so I want to have all the UTIs treated by the time I'm doing cystoscopy. And of course, this does not apply to the uroliths, but in general, if you have a suspicion of TCC, always beware of the cystocentesis. The patient positioning now, another big issue about cystoscopy. Write in the chat box if you'd like, you know, what's your preferred patient positioning. In the textbooks, you know, you can see ventral recumbency, you can see dorsal recumbency, you can see, you can also see sometimes lateral recumbency. This is the positioning mostly shown in the textbooks. This is why I've put my patient like that, but I do it the other way around with the spinal cord on the table, because for me, it works better. I can have a better proximity into the urethra and also take better biopsies. Sometimes it's even for large breed dogs, this position is better because it presses the bladder so the wall comes up to you. You definitely have to take the tail off your visual screen. Okay, and we have these tables in order for the fluid to be dripping. This is the position in my clinic. So we keep a rolled towel to elevate the abdomen. I'm going to show you, this is how the textbooks show. I'm going to show you how we did it in this Westie. Okay, so many drapes or towels, you elevate and you stabilize the tail, as we said, of your procedure field, your visual field. You clip the perivalvular hair. You keep it as sterile as possible, okay? And you scrub the area as well. And a tip that I will give you that I found so useful is that we always, when we do cystoscopy, most of us care about the bladders, but we don't care about the fecal material in the colon. Please take off the fecal material before starting your procedure, before doing your scrubs, because this will help you immensely in your cystoscopy procedure, whatever procedure might that be. So we remove the feces with an enema under anesthesia. I'm going to show you how. This is my, all setting. I have drapes. I have my bucket, this red bucket for colonoscopy, for rhinoscopy, for cystoscopy as well, and a towel. Another patient here on rolled, and this is actually how we do it, on rolled towels underneath the abdomen. And before starting the procedure, we always do an enema. This is a deep enema. I put a Foley catheter or an aspiration catheter in the colon because this animal had many feces in the colon. So I have a drip with normal saline, at least 70 centimeters up high. And then I connect that to my set and to my catheter, and I do enemas under general anesthesia. And this is very helpful also in colonoscopy, just right before you get into the procedure. Okay, and then you hold your equipment stable. And if you want to rotate your scope, you only do it from the light source, right and left. You do not rotate your whole scope. Otherwise, you will be disoriented. You will lose your orientation. Okay. And you see now the settings. My anesthesiologist is on my left side. My tower is on my right side. This is always how it should be. And this is from a photo, not from a drone, from upper high, so that you can see how we connect everything. This is the connection of the saline. This is the connection of the light source for those of you who are beginners. And I keep my scope from the handle because I've seen many of you keeping your scope a bit further up, from the handle, and it's very ergonomic, this new handle of our rigid scope. Okay, and of course, the animal under anesthesia, under general anesthesia. And you attach worm saline. This is what I want. Of course, you cold soak, sterilize the instruments with glutaraldehyde. You rinse with deionized water, and then you attach worm saline to the inlet port via the giving set. Because this is a procedure that might take long, and you don't want your patients to be hypothermic. Okay, and then you attach the camera, you ensure the proper orientation. These are the basic steps for those of you who are beginners. You attach the light cable, so everything will be in steps for all of you, and you use sterile gloves. Okay. And then, as you see, I have the hind limbs over the end of the table. So you just push your patient in order to come out a bit of the table. And the cystoscope is advanced through the vestibule. Okay, beware of the clitoral, the subclitoral fossa, because some of you are stuck there and you cannot do it. You keep your scope in a rostrodorsal direction. You pinch the vulva. To be honest, this is the most difficult part. Sometimes I want to pinch the vulva lips. Sometimes my hand is numbed, so I tell my assistant to do that. It's better if you have control over the amount, over the confinement of the vulva lips, but sometimes it's not possible because you have to have other hands in order to do, to retrieve, for example, your uroliths. Okay. You have to ensure, this is the secret for a good cystoscopy procedure. You have to ensure that you have a very, very good sealing. Okay, so that the water stays in, fills the vagina, and you can actually, the vestibule, not only the vagina, the vestibule, in order for you to see the opening, the urethra opening. Okay. And then you just have to let the infusion of the fluid by gravity flow, not by irrigation pump, as we said. The saline, you always keep your saline on, okay? And you manipulate the water inflow from your from your actually stock pops on the actually tubs on your scope, on your sieve. Okay. And then, as we said, you do not over distend. And once the vestibule and the vagina are distended, then the saline flow might be turned off for a while so that you can see the opening of the urethra. And then once you get into the urethra, then you go ahead and start the flow again. But always beware of the over distension. And this is how you do it in the female dog. You slowly advance the cystoscope ventrally in order to visualize the urethra orifice and then examine the vagina rostrally to the cervical os. This is the other way around, as you see, as I do it. Okay. And then in the female dog, now you're asking me, for example, we're talking about uroliths. Why should I know anything about what is expected to see in the bladder mucosa? Because you have to always keep in mind the underlying pathology. Okay, so once you reach the urinary bladder, you stop the saline irrigation, and you're going to visualize for the first time this yellowish picture here, okay, which is the view of urine, of course, with many, many cellular debris, especially if you have urolithiasis. Your image is going to be very blurred. And of course, if you have significant hematuria, this might obscure your view. If you have idiopathic renal hemorrhage, for example, this will obscure your view. So you have to empty your bladder. You have to open the drain port and allow all the urine to drain out of the bladder and deflate, and then you will re-inflate the bladder. You will flush your bladder, of course, with normal saline. And you might need to do that 2 or 3 times in order to have a clear picture. Okay, the urine may be drained with using an 80 ml syringe. Most of the times I don't do that. I just open I remove the urine from the seat, from the scope, and I let it drain into my bucket. Okay. And then the drainage port is closed, and the bladder, as we said, is re-distended. And this is what we see. These are the opening. This is what we always have to look at, the opening of the ureters, okay, especially in the idiopathic renal hemorrhage. You have to see the beam of the urine, and you have to do it in both ureters, okay? And as we said, 1 or 2 flushing cycles. Okay, and let's go now to the uroliths retrieval. And I'm just going to talk to you about the statistics of the surgical removal. I'm not going to go into the any of the techniques because I'm not a surgeon. But I want you to know the complications through this technique, the surgical technique, versus the minimally invasive technique, the endoscopic technique. So we can have various, of course, I know that many of you who are surgeons will say that this is a very simple procedure, cystotomy and urethrotomy. I can remove the urinary stones and get it done and over with. Yes, but you will lose the visualization of other lesions. You might lose the ureters. You might lose the maybe some polyps in the gallbladder. You might not be able to take some biopsies. Of course, with cystotomy and urethrotomy, you might also take some biopsy samples, but they will not be targeted. Okay. And other various complications could be urine leakage, wound dehiscence, bleeding, stricture formation, especially in the urethra, and incomplete stone removal sometimes, which is reported in 20% of the patients. You know, for a surgical procedure, to miss 20% of the patients is a big deal. And of course, afterwards, the suture material in the urethra or the bladder can actually serve as the nidus for future urolith formation. So we try to keep it as, let me say a word, low antigenically, low antigenic stimulant as possible, which is low formation, urinary urolith formation wise, as low as possible. Okay, and of course, it has been shown also that analysis of recurrent lower urinary tract stones in patients that have undergone surgical cystotomy determined that 10%, almost 10% of them was suture-induced. Out of 10 that have undergone cystotomy have actually recurred in urolithiasis. Okay, and complications associated with the traditional cystotomy, regardless of a closure method, were reported to 37 up to 50% of the cases, with a mean duration of hospitalization of 4 days. Whilst if you do an endoscopic procedure, the very same day, if you don't have any complications, the animal can not be hospitalized, can go home. Okay. And these are the papers and many more to support what I have told you. These statistics are derived from these papers. And let's go now to the minimal invasive techniques, which we are here for. The stone basketing, which is my favorite. So we keep the stone, we actually use the stone basketing removal for urethral and bladder stones that cannot be amenable with medical dissolution or with nutritional dissolution, or they are too large for voiding hydropropulsion. Okay, so our ideal candidates will be stones, animals, patients that have stones less than 5 millimeters in small female breed dogs and less than 3 to 4 millimeters in female cats. And of course, male dogs, we have a limited size of the penile urethra, 2 to 3 millimeters, up to 2 to 3 millimeters. We can do it with a 2.8 flexible scope as well. Sex and species. Okay, female dogs and cats are very good candidates for these methods, and male dogs more than 7 kilos. Okay, so that we can facilitate the passage of the flexible scope. The advantages is that it's very, very quick, no suture material in the bladder, and with all the consequences that this could lead up to. And the disadvantages, of course, are that we need specialized equipment. And if you're committed in doing endoscopy, interventional endoscopy techniques, you have to be prepared to invest. Now, another question that I really have very, very often is, are the baskets for the stomach, can I use them in the urinary bladders, first of all, even if size-wise you could use them, I would suggest not to, because even if they're sterilized, you're going to go into bladders, and you don't want into the bladders materials and instruments that have gone into the stomach. Okay. The second thing is that you will find out if you do, if you just look into the urology instrumentation out there, and if you make an inquiry, you will see that these baskets are totally different in the way that they are designed. So you see the 6 mm, the 7 mm, the 9 mm, and the 11 mm. These are the sizes, whereas in, for example, the stomach, we have 35, 45, 65 mm baskets. Okay. And there are the simple ones, those four here, but we have some other round edge 4-wire basket designed for reduced urethral trauma. And we have some other very, very intellectual baskets from Boston Scientific, for example, this one that has 2 baskets in a 15 mm cage for the uroliths and 11 mm cage. And this is for when you do laser lithotripsy. With a smaller basket, you can grasp all the smaller fragmentation of the uroliths, and you can take them out more easily and out of your surgical field as well. And you see here where the fiber goes and where your basket is. Okay. These are some other baskets. To be honest, if you ask me which one of those I use most of the time, these are all nitinol baskets. I use the helical stone extractor most of the times because this is what I used from the beginning, and I'm very used into manipulating the stone. How do you grab the stone? You grab the stone by going underneath the stone. And the helical stone extractor helps me because it's the same technique as I use in the foreign bodies. Now I'm giving you tips because I've used most of the baskets, and some baskets are not easy. They might seem easy. Some baskets, you can retrieve the stones on your going out. Some baskets, you have to go underneath the stone and open the basket in order to entrap the stone in your basket. So most of the times I use this one, this one here. I don't know if you see my cancer, because it's the same technique as I do in the foreign body. So I go up to the wall, I go underneath or just next to the wall, and this is my stone here. Okay, and then if I go underneath, then I start to open it and grab the stone. It's easier for me because it's the same technique as in the GI tract. I've never used one of those trap devices. I would love to. If I ever do, I will tell you, I will share my experience. And of course, we have some stone graspers. Most of the stone graspers in urology are 3-prong graspers or some firm graspers through the rigid scope that have, jaws, different kind of jaws for different kind of stones. Sometimes with the jaw graspers, you can actually break some small stones, but most of the stones are really hard to break. And this is why we need, the other methods and other techniques. I mostly use baskets, and I don't use stone graspers unless the stones are in the urethra and they're really close to me in order to get them out, and not in the bladder. For the bladder stones, I mostly use the basket. retrievals. It's not a mistake to use the stone graspers. I just find it easier. And how do we do, what's the procedure? Okay, so we keep a dorsal on female or lateral male recumbency, in the male dog's recumbency. Especially in the male dogs, we use epidural anesthetic. This will enhance the lower urinary tract relaxation, the urethra relaxation, and it will facilitate the retrieval. Okay, and of course, we always do cystoscopy in order to visualize the uroliths and any other lesions, any other accompanying lesions. Then a stone basket is passed through the working channel of the scope, and you have a continuous saline flash. The basket is pulled towards the tip of the scope, and both the scope and the basket are then withdrawn. You do not take the, just as in the GI tract, you do not take the basket through, of course, with the stones through the working channel. Okay, if you find resistance, then the flash pressure can be increased. You can increase the flash pressure, but beware of the over distension, okay, and the rupture of the bladder. And if you still feel resistance, then you just have to open the your basket, release the stones in order to avoid any damage or perforation to the urethra. You do not press more than the threshold, and you can feel it, because many people say, what is this threshold and how distended can the urethra be? If you don't know, you can have it priorly with you can see it priorly with your fluoroscope, doing fluoroscopy with a contrast medium, and measure the diameter, the maximum diameter of your urethra, for example. But if this is not possible, you don't have a fluoroscope, for example, you can do it with urography, retrograde with retrograde urography, with radiographs, for example. And even if this is not possible, then you can feel the resistance by dragging your basket through the urethra. Okay, if you feel resistance, that it is impossible for you to move your scope along with the basket, then you go back in, you release the stones in order to avoid doing any. Okay, and some people after the procedure, they use topical bupivacaine, especially in dogs, into the urethra for temporary local analgesia. Of course, if you have done epidural, I don't think that this is, I don't find that necessary. Okay, and this is the patient that you've seen earlier in the in my photographs from the clinic. Some calcium oxalate uroliths. Okay, and you just put the basket. You have constant flow. You see that we don't actually distend the urethra that much. And the calcium oxalate uroliths are impossible to be dissolved. You see how many of them? But I still have mucosa up on me. You see that the bladder is not fully distended. And of course, prior to my doing all the retrieval procedure, I have done my cystoscopy procedure, and that's a clot as well here. Okay, and they're very, very easily removed. You can take multiple stones with your basket if the diameter of the urethra is enough to accommodate that, okay, or single stones. Oh, I had Greta in video as well. And what I wanted to show you was that the patient felt, had hypersalivation, nausea, vomiting, and wanted to go out to urinate. And this was all from the urinary bladder. So many, many cats, this is especially in cats, that are admitted to your clinics with acute vomiting episodes, please palpate the bladder, maybe they have a urethral obstruction. And many dogs as well that have nausea have problems in the urinary tract. So don't exclude that, feeling that this is a GI problem. Okay. And that's a tip for you, as it was a tip for me as well. Before deciding on the preferred method for stone removal, we estimate that with radiography most of the times, or fluoroscopy if you have, with contrast medium or without a contrast medium, in order to measure either the diameter of the urethra or the size of the uroliths, because as I told you before, the ultrasound tends to overestimate urolith size and underestimate the number of uroliths, okay? Maybe in the ultrasound, you're seeing uroliths that you think that they're bigger than they actually are. And you give this way your owners false expectations, because when you take out the uroliths, they're really small and they're saying, you know, these were the ones that we were seeing in the ultrasound. So ultrasound tends to overestimate the size, but underestimate the amount, the number. And what about intracorporeal lithotripsy? There are 4 techniques described in humans. We're going to talk about the 2 first that have application to our patients. Electrohydraulic lithotripsy and laser lithotripsy. Okay, and we're going to talk a bit about what equipment we have to have. So for intracorporeal lithotripsy, what are the indications as well? The size and the number of uroliths. If you're doing intracorporeal, either laser or I have to say the electrohydraulic EHL. I'm gonna say DHL. Either laser or EHL. You have to have a low stone burden. You cannot have many stones. You cannot have a high number of stones because you cannot go in and out many times from the urethra. You're going to cause trauma, stricture, and you're going to have other problems in the future. And when we are beginning with doing the technique, we get to be so in love with it that we forget the time. Please beware of your time. Have a time schedule and say that if I don't, and commit to it, and say that if I don't do it in half an hour or in, 40 minutes, then I'm out and we're going to use another technique. Okay. You have to be trained, I know, but you have to be trained really, really with caution to our patients. Okay. And the sex and species, female cats and dogs, amazing candidates for that. Male dogs, more than 7 kilos. It's the same like the stone basketing, okay? The advantages, again, is that we have no sutures in the bladder. And the disadvantages is, of course, that you need more specialized equipment and a long procedural length if we have a large stone burden. And if you have a large stone burden, this is not the preferred method. Do a cystotomy. I rarely ever, hardly ever say that, but you have to do good and not harm the animal. And we're going to talk about the EHL. The EHL, because many people ask me, what should I have in my practice for urology? Some mention diode laser, and we're going to talk about diode laser. Could I use my diode laser? My electrohydrocollic lithotripsy device, or my YAG laser, for example. So there's a bit of a confusion, especially when you're starting off and you don't know what kind of an equipment you have to buy. The EHL is a pretty, financially, it's not that expensive. Okay, it has been used for many years in humans and in animals for lithotripsy. Okay, so these are the devices, and the electrode is passed through the endoscope, okay, and it allows an electrical spark to happen, to be generated. in a bladder that is full of saline, of course. And then this spark is activated for a brief period, and the creation and subsequent disappearance of the spark in the fluid medium generates a pulse, which is the shock wave. And this is how the stone, through the shock wave, the stone is fragmented. Now, some people say that the tip of the fiber, of course, this is not a targeted procedure, which means that I have a scattered effect, which is, on the contrary of the laser device usage, that we have more focused and targeted effect. Okay, some people like that the tip of the fiber is placed 1 millimeter from the stone. Some others say that you have to be in direct proximity with the stone. You practically have to be on the stone. I've asked many human urologists, because they have bigger experience, than we do, and they say that they place always their EHL probe at least 1 millimeter from the stone, because this is how they secure a better effect. But in the veterinary literature, you might also see that your probe could be up on the urinary stone, okay? And at an angle of 90 degrees, which means that you actually target vertically the stone. The stone is fragmented by the device, and the energy is transmitted directly to the stone, creating a shock wave, as we said. Okay, I do not have, now I'm not branding any, I'm not advertising any of these brands. These are just EHL machines that from different brands, but they all do a very good work. Compared their value for their money. Okay, there are, for the EHL machines, there are some 1.6 and 1.9 French probes. And another tip is that you have to keep the tip at least 2 to 5 millimeters away from your scope. Otherwise, you will harm the lens system. Some people use in their scopes, they might use cups, protective cups. It's very difficult in the urinary tract. It's easy in the GI tract. It's very difficult in the urinary tract. I've tried it, it doesn't work. So you have to be very careful for the not to destroy your lens. Keep it at least 3 to 5 millimeters away from your scope, the probe. The stones have to be clearly visible. This is why you have to do all the procedure up front, which means that you have to clear the urine and have a good visualization of the bladder. Okay, 1 millimeter from the stone. I have to stick with what the urologists say for maximum shock wave emission. And what about laser lithotripsy? How many of you use laser lithotripsy? So the problem in laser, if I have, of course, the luxury of having laser lithotripsy, I would rather have it than EHL. It's much better, but it's not that affordable. Of course, it's more affordable now than it used to be some years ago. We're going to talk about the specific lasers that we use for urology. The probe has a flexibility. It's activated in less than 1 minute. It's safer and more efficient. You see that the perforation rates are low. It can fragment all the stones. There is no stone that the laser cannot fragment. They can produce small stones, fragments can be produced, so you can have, hydropropulsion, voiding the bladder with hydropropulsion afterwards. It produces a very weak shock wave, which actually reduces the likelihood of retropulsion of the stone. And it can be used for other things as well, for strictures, for TCCs. And of course, it's a highly, financially, it has a higher cost, and the laser fibers have a cost as well, higher cost. The fracture of a laser fiber inside the endoscope can actually damage your scope, and you will throw it away. You can cut through baskets with the laser and through guide wires, which is amazing. For example, in ectopic ureters, you can use it, and you can cut through, as I said, basket retrievals and through guide wires. And the 200 millimeter fiber actually reduces the deflection of your flexible scope up to 20 degrees. Okay, so you have to be aware of that when you're using the flexible scope in a male dog. It can pass through your rigid scope, it can pass through your flexible scope, but the flexible scope has to be, we have to be really aware of the flexible scope, not to damage it. And this is the popcorn technique. This is how it works. The stalk fragmentation is enhanced by the direct laser contact. So here, on the contrary, in contrast to the EHL, it is suggested to have direct laser contact. Okay, or you can have a contact with other calculus material, and this is the popcorn technique. Okay, you can have the direct laser contact or contact through other calculus material, and you have an amazing effect. Some people ask me, I have many questions from those of you who have diode laser. Can I use it in urology? And we'll talk about a bit YAG lasers and diode lasers and what they do. And the fibers in urology are from 200 micrometer to 550, sometimes 600 as well. These are the micrometers used in urology most of the times. And you might as well need this gateway adapter. I just thought of every single material that you might, equipment and instrumentation that you might use. This is to put both your basket retrieval and your laser beam through your working channel, okay? So that you can put both and you can work with both at the same time. So let's talk a bit about diode lasers. I'm certain that most of you have diode lasers. Please write in the chat box. So diode is small, it's compact, it can deliver the laser light through the flexible solid quartz fiber optic cable, okay, and it's always passed through the scope. The diode laser in the frame of 800 to 980 nanometers is not attenuated by water to a high degree, and thus it's preferentially absorbed by biological pigments, by hemoglobin, by melanin, okay? And this is why, just because it's preferentially absorbed by biological pigments, it's very, very efficient for hemostasis under constant fluid irrigation, of course, in rhinoscopy and cystoscopy. Is it for uroliths? No, but it's, in order to have a very good coagulation effect. Okay, it relies on a multiple pigment effect to produce general tissue interaction, but we have increased scattering, good coagulation, but we can have an increased thermal damage, which most of the time it's not shown only after post-operatively. And this is the same thing that we have with our endocauteries in polyps. When we cut the polyps without submerging them with gelofusine or with some pigmentation and normal saline, when you just cut off the polyp and go out, either in the colon or in the urinary bladder or even the stomach, you can have thermal, an awful thermal damage that will not be shown at that time, but later on. Okay, and you have to really be careful about it. So always submerge the lesions that you need to take out with endoculturing, for example, or with laser. So as we said, the thermal injury might not be evident immediately, and it's very, very useful for debulking transitional cell carcinomas, for paramesonephric remnants, for intramural ectopic ureters. So if you are doing interventional endoscopy, why using the laser? Why using the laser or the HL if they will probably damage the endoscope? Okay, Nir, it's not that they will damage the endoscope. If your fiber fractures in the endoscope, they will damage the endoscope. This is one thing. And the second thing is that you have to keep a distance from your scope lens. If you keep a distance from your scope lens of at least 3 millimeters, then you don't have a problem. It will not damage it. The laser is higher advantages compared to the EHL because you have a more targeted effect and focused effect, not a scattered one. But it's the one that's for urolithiasis, and we're going to see which one is that, is very, very expensive for us right now, for the veterinary market, I mean. So the diet is very useful, but not for uroliths. It's very useful for other things, for other interventional procedures in the urinary tract, like the ectopic ureters or the paramesonephric remnants or the TCCs. Okay, so no for uroliths. And let's go and see which one is the one that's appropriate. Okay, the Holmium YAG. For the uroliths, this is the ideal one. Okay, I have literature that says that the tissue, the lithotripsy is performed, or the tissue ablation is performed via photomechanical effect. Actually, it has been proven that the lithotripsy is actually achieved by a genuine thermal effect and not a photoacoustic effect as originally thought. So the same thing, the YAG laser delivers the laser light through a flexible fiber optic cable passed through your endoscope. These are available in two powers, low power 20 watts, which we use in urology, and the 60 to 100 watts were that the surgeons use for tissue resection. Okay, or we can as well use for tissue resection in the urinary bladders, for TCCs, for all the other things that the diode laser also has an application. So we have an immediate tissue vaporization with minimal collateral thermal damage. This is a huge advantage, the fact that you don't have a thermal damage. Okay, and you have to be aware that with a YAG laser, the HO YAG laser, if the fiber tip is 0.5 millimeters or more away from the tissue, then you have no impact. You have to be on constant direct attachment to your urolith, okay? And of course, there are some newer technology, YAG technology, lasers like MOSES, Lumenis, that are designed also to minimize the vibrational effect. Go and have a look. This is a very nice paper for a laser lithotripsy for the treatment of canine uroliths. Okay, it has been shown that higher, in this paper, it's described that higher pulse frequencies, like 10 to 40 hertz, and lower pulse energies were safer and more efficient for urolith fragmentation. To be honest, our YAG lasers are up to 20 watts. So you see that we use only 5 watts power at 15 hertz delivered through 320. So I give you all these details because if you need to buy the instrumentation, you need to know which kind of fibers, which kind of lasers and everything. and to which watts, hertz, and adjustment you need to put your laser machines. So most of the times in urology, we use a 200 laser beam, or a fiber, sorry, or a 320 or 365 for the uroliths. And it's more than adequate. Okay, the laser energy, as we say, is applied in contact mode to the urolith surface, and we have a continuous flushing with normal saline solution that is delivered through our working channel, the working irrigation port of our endoscope. So this is pretty much everything. We have a case here, and I want your contribution in that. Let's have a discussion. I know that we are past I'm 20 minutes past the hour of the webinar. But let's have a discussion, because this is very, very common. You will encounter this very, very commonly in your practice. So we have a 2-year-old female Lhasa Apso presented with a radiodense cystic calculus. Okay, urine positive for Staphylococcus aureus and urine pH 6.8. And she has been treated with a diet advocated for dissolution of struvite uroliths. Okay. The uroliths, though, she has been on that diet for more than 8 weeks of feeding the diet. Okay. And the uroliths have not changed size. And she has been being treated with amoxicillin. The BUN is 19, and the urine-specific gravity is 1027. Why do you think we have a failure in the treatment? Let's have a discussion. Don't leave me solo here, all alone. What do you think? That she's been on the diet for more than 8 weeks. She has been priorly diagnosed with struvite urolithiasis. Okay, so this is dissolvable. Okay. And for those of you who have actually heard the first lecture, you might start thinking about some things, but this is very common. This is what we encounter in everyday practice. I mean, sometimes animals have already been treated with dissolution diets. Some animals have already had cystotomies and removing of the uroliths, yet they might have recurrences. Why do you think it's that? I should say that, huh? Just give me one reason that you're thinking that might be that we might have had a treatment failure. Okay, first of all, oh, great. Thank you for not leaving me alone here. The infection, yes, Khaled, this could be. Or it could be the infection is not treated enough, or it's not the infection to treat. Huh? That's one thing, huh? Okay, first of all, we know that the owner is lying, and we know that he tells us a lie, that he's feeding the diet out of one thing that I'm giving you here in your in the data, in the case that I'm giving you. Why is the owner lying? The dog is not eating the diet. Why is the dog? How do I know that the dog is not eating the diet? It's not only the pH, Khaled. An animal, thank you for being with me with that. An animal that's on diet has a BUN less than 7, very low BUN. And I should have a lower specific gravity as well. So the animal is not eating the diet, first of all. Okay. The second thing is, okay, we know that this animal had prior struvite uroliths. Who tells us now that this is a struvite urolith again? And who can say if this is not a mixed or compound urolith? Okay, that's the second thing. Okay, let's go and see. What are the... So what should we ask the owner? Are you feeding the dissolution diet exclusively? This is a closed question though, huh? Beware. If you ask the owner, are you feeding the dissolution diet? The most probable answer will be yes or no. This is a closed question. But if you ask him, you know, for example, what does she like? What does she like eating? Then he might give you a list of treats, of other, you know, homemade diets that they're giving her. So try to ask open question, and not does she like to eat anything else, you know, or even this question, but what does she like most eating? These animals that are only on the dissolution diet will say, their owners will say that she doesn't eat anything else. We only restrict her. Those who give their animals other things as well will say that, oh, she likes this treat and she likes also eating, you know, but in very small amounts, this thing. So you know that the animal is not on the dissolution diet. Are there any other animals in the household? This is a second question. Maybe she's eating from the cat's food, you know, or maybe their bowls they're eating at the same time. So we have to separate the animal and let them eat all alone so that the dissolution diet actually works. If the owner has been feeding the dissolution diet, then, as I said, the BUN should be less than 8, and the urine-specific gravity should be lower than 1025. Okay, so this means that they are not eating the dissolution diet. And this is why I always urge you to do a BUN and also a urine sample. Take a urine sample if your treatment has failed, because the first thing that everyone is saying is that it is your fault or the diet's fault. Okay, it's not, it's their fault. It's always 99% of the times it's their fault. And a very good point that Khaled said is that, was amoxicillin prescribed blindly or guided by urine culture and sensitivity? And of course, it's the possibility that the urolith is composed of something else than struvite. It could be a mixture, compound urolith. Okay, or it could be the case that we might have missed something in the cystoscopy, for example, and I might have an ectopic ureter, or I might have some other underlying anatomical problems, a paramesonephric, a paramesonephric remnant that has not been treated. And it actually makes UTIs so much easier. Or if I have a vulva that's actually in the skin, it's folded with a lot of skin, and this means that this animal is prone to UTIs and to urolithiasis as well. So we have to keep all of those things in mind. And having said that, I have to wish you a very, very nice summer. I'm always here for any questions that you might have. I love urology as an internal medicine person, but my specialty field is gastroenterology. I will have, though, for you, maybe from September, a surgeon to talk a bit about interventional urology, lap-assisted interventional urology, so that you can have an overall closure of that. And maybe from September, we can also have a cystoscopy, a transurethral cystoscopy webinar, in order to talk not only about the uroliths, but also about other things that are abnormal, that we find as abnormal findings, like TCCs and idiopathic renal hemorrhages, and I have many videos of there to show you. Thank you very much for bearing me this hot summer day.
Thank you, Dr. Vasiliki. Thank you for the wonderful lecture. Is there any questions here?
And you can email me the questions as well.
Yes, yes. If you have any questions, please contact us from LinkedIn, YouTube, Facebook, or Instagram, or even by email. We are happy to answer it. We also will show the recording of today and more clinical cases, also the information of next event on these channels. So don't forget to subscribe. See you next time.
And I really hope that we made it clear that it's different, the diode laser from the EHL and the
Yes.
YAG lasers. There are three totally different devices, and they have different applications.
Yes.
Because this is what we're mostly confusing.
Yes, this is also very important information for me.
Yes.
Yes. Okay. Thank you.
Thank you. Thank you very much. And see you in Athens. For those of you who will come in Fakava, please come and find me.